The way I talk through this with patients is, did your biopsy demonstrate prostate cancer? And if it demonstrated prostate cancer, is it the kind of prostate cancer that we need to treat right now? Or is it the kind of prostate cancer that we can safely follow or monitor over time? So who needs a prostate biopsy? Somebody who has abnormal blood testing, they go on to get an MRI. That's our regular pathway. Who do we say you don't need an MRI? Men who have bilateral hip replacements, an MRI is effectively useless. So we don't do an MRI for those individuals. We can calculate PSA density with an ultrasound. It's fast, it's cheap, it's effective. Otherwise, we have everyone go to an MRI. It's worth it that much.
Even with a single hip replacement?
Single hip, our radiologists are really good, and a good radiologist can read an MRI effectively with a single hip. If somebody has profound anxiety and they need general anesthesia for something, we'll be nuanced about whether or not we think an MRI makes sense. But for the average person, 99.5% of people, you get an MRI. Now, MRI shows a suspicious lesion.
3, 4, or 5 on the
PI-RADS 3, 4, or 5, you need a biopsy. MRI shows...
Sorry, independent of PSA density?
Independent of PSA density.
Okay.
If your MRI shows no lesion, but a high PSA density, so a young man, let's say under 60, that's a PSA density of more than 0.1 or 0.12.
Yep.
If you're older, I'll give you a little bit more of a longer leash, and we'll say 0.15 over 65 or 70. If you have a PSA density that's below that threshold and you have a high PSA, low percent free, et cetera, you need a biopsy, in my opinion. Okay? So RADS 3, 4, or 5, you need a biopsy unless your PSA density is incredibly low.
Like 0.02.
Yeah.
Yeah. Which, by the way,
sometimes they have it. Yes. So there's never always, and there's never nevers in medicine, right?
Yep.
But in general, that was what we would say. If you have a negative MRI and a high PSA density, we will often suggest a biopsy for you. And if you have a negative MRI and a low PSA density, we'll say you're likely can be monitored.
Yep.
Now, biopsy, the answer is not just cancer, yes or no. There's a lot of subtlety and a lot of things have changed about how we think about these different cancers. So I always explain to patients that it's effectively, when a pathologist looks at a biopsy sample under the microscope, they're describing the pattern of the cancer gland. We talked about this at the beginning. The prostate is an exocrine gland that produces semen. And there's an architecture of the gland or the duct that a normal prostate has. So think about like a branching tree. When you develop a cancer, it's an abnormal developed branch. And so the pathologist will score how abnormally developed that duct or that branch is. And that score is what ends up being the Gleason score. Now, the pathologist tells us, if you have a cancer, what does the individual branch look like? What's the pattern? That will be the Gleason pattern. And then the patterns today are pattern 3, pattern 4, and pattern 5. But what we get in the summation report is, well, how much pattern 3 cancer do you have? How much pattern 4 cancer do you have? And how much pattern 5 cancer do you have? And that's the Gleason sum, or what we now call, what was also referred to as the Gleason score. So the common ones would be 3 plus 3 equals 6. That means that the pathologist only saw abnormal glandular patterns that were pattern 3.
So the pathologist is always reporting the highest scores that they see?
They're reporting the most common pattern they see first. That's the first number.
Okay.
And then the second most common pattern of cancer that they see as number 2.
Okay. And this is on both sides. Once they're looking at
this, they take every single sample, they tell you the score.
Okay.
So
and typical number of samples that should be done in a decent biopsy?
It's 12 systematics.
Okay.
So that's right side, left side, kind of every 5 millimeters kind of approach. Plus you sample the target. And the recommendation number of samples of a target is usually 3. So 2 is inadequate because the needle can bend, it can deflect. Sometimes the needle is going in 20 centimeters beyond your hand. So you have to account for the deflection, and you can track it. But the idea is you do it 3 times.
And you're biopsying only the peripheral zone?
We biopsy where the lesion is, but most prostate cancers originate in the peripheral zone. They can
But the 12 systematic biopsies
peripheral zone.
Peripheral zone. How thick is that, by the way?
It depends on the size of the prostate. So in a young man, it's about 4 to 5 millimeters thick. And in a guy who has a big prostate, let's say 100-gram prostate, the total peripheral zone volume does not change in a man over time.
So does that mean it actually gets thinner?
It gets compressed and thinned out, particularly if you have benign prostatic overgrowth.
Wow. So it makes it harder to biopsy.
It makes it harder to biopsy, absolutely. So that's where skill definitely plays a role. So you have to really understand what you're doing. I mean, not any,
targeted biopsy, but I don't see a need for the 12-core procedure at this junction. So what recommendation do you have?
It depends on the quality and the skill of the doctors. How well performed was the MRI? How good is the doctor at hitting targets? Many times as people are getting started up, they don't trust their skills to be able to hit the target, and to cover for that, then they want to go back and do a random biopsy in addition to the targeted biopsy. So maybe that would be appropriate if the doctor is in his early learning curve and he's not totally confident that he can hit the spot, the lesion that was picked out on the MRI. This whole idea of moving away from random biopsies is based on your having access to great MRIs, great doctors to read the MRIs, and skillful doctors to do the biopsies. If any of those fall apart, then the risk, of course, is that someone goes in and does a targeted biopsy thinking they hit the spot. Biopsy comes back clear, there's no cancer, but in actuality, through someone's lack of skill, they missed the spot, and the cancer's still there. So the whole idea of relying on MRIs and targeted biopsies as a substitute for random biopsies is based on the trust in the quality of the system that you're using. Just 2 or 3.
So when I hear that list of options when it comes to getting these targeted biopsies, my brain goes, okay, well, what's the most accurate, but also what's the most available? And, do patients need to go to an academic center to get the one that is, going to target it the best? Well, how do you look at that?
The most accurate would be the in-bore biopsies where they do the biopsy right in the MRI. The most convenient would probably be a cognitive fusion biopsy. Sometimes you can tell on the MRI there's something right on the back of the gland. It's not small. It'll probably be even visible on the ultrasound, and so that's a simple outpatient prostate biopsy done in the doctor's office. Between those two extremes, maybe the one that is going to be convenient and accurate will be what are called fusion biopsies, where different centers have invested in expensive software that they can load the MRI image into their ultrasound. And while they're doing the ultrasound, the software will tell them where to stick the needle, even though they might not be able to see it with the ultrasound. The MRI information is incorporated in the software. That's called a fusion biopsy. All of them are appropriate in different situations. If people have really small anterior, that means away from the rectum lesions, I recommend an in-bore biopsy. That's the most accurate. If you have a larger lesion toward the rectal wall, where most lesions occur, cognitive biopsy, micro-ultrasound, or color Doppler ultrasound would be perfectly fine. In those ambiguous situations, maybe a smaller lesion that's posterior, a fusion biopsy would be best.